All the participants, that's my phone, sorry, participants' camera and mics will be turned off during the session. The session will be recorded, even though the cameras and microphones are off. And if you do not wish to have this be recorded during this session, please opt out now and watch the recording after the session. There'll be time for some questions after each of the presentations that you hear today. These will be moderated questions and answers, so if you can pop them in the Q&A tab, and if your question is not answered during the session, then we'll take these offline and respond to you directly. You can also, if you've got questions that you really want answered, if you want to like those questions in the tab. Materials and all the recordings will be uploaded to the website afterwards, and then any links and references will also be there for your available for your end of the session. So I'm going to hand over to Louise, who will introduce herself, and I'm going to turn my camera off now. Thank you.
Thanks so much, Claire, and hello to everybody, and it's a great opportunity to be with you today. I'm Louise Hicks. I'm the CNIO and Director of Development at Barts Health and visiting professor at City University of London. So it's great to be able to talk to you today about empowering people. It's something that, as part of obviously the What Good Looks Like framework, but part of our everyday in developing clinical informatics. And I'm going to talk to you over the next 20 minutes about some of the things that we've been doing over a period of time, give you a bit of a story about some of the things we've done at Barts Health, and also really enable us to think slightly differently about some of the things we might want to do in relation to empowerment. Key to this is our ability to really champion technology and informatics to improve practice, address unwarranted variation and enhance outcomes for the people we serve, whether that's in North East London, which is where obviously Barts Health works, or across the world. It's all about the impact. So quite often when we think about change and development, when we think about informatics, we think about the actual product, the thing itself, but the reality is it's just a vehicle to enable us to really empower people in their lives, to lead great lives and to be healthy. So my interest in digital is actually to do that and to think about addressing the theory practice divide and enabling us really to get to the heart of what people need. So let's just go to the next slide and have a look at what we're going to cover. We're going to look at an insight into the journey, the change processes, the people participation, how using co-production and developing a brand can really help, and the impact that that gives us on morale and adoption. So on the next slide, we can see the What Good Looks Like framework, and that I guess that for most of you on this call, you will know this inside out. But just to remind us that actually at the very centre of this is our ability to empower citizens, to really connect, to really transform. And it's not just about engagement, it's really about the true involvement. Let's just have a look then on the next slide about what we really mean in relation to empowerment. So what is empowerment? It's a real opportunity to enable us to have a voice, to have the same opportunities to live good lives in a community, and for us not to just deal with those that shout the loudest, but actually be able to think about our inclusion strategies and our equity to enable us to empower people across the whole of our communities, and not just the people that are our patients maybe coming into our hospitals. People will know about their rights and can act on them, and people have the information they need to make their own decisions. And we're all people, of course. So how do we think this through in the context of our own access to healthcare? For people who need help, there should be great advocacy, and people need to be able to set their own goals and make their own decisions, or define who does that in their best interests if they're unable. So it's really about thinking through people having power and control over their own lives, rather than thinking it in the context of particular disciplines or professionals. It's actually about changing the face of this to enable us to do things differently. So I'd just like you to think about the question on the next slide, which enables you to think about what really matters to you. So just take a moment to think about what is empowerment from your perspective. Jot it down on a post-it, or if you are electronic, on your phone, whatever it happens to be. What matters to you about empowerment? What do you want? Give you a moment to think about that. It's not a test. And that may be about your access to services. It may be about how you work in a team. Maybe about life in general. What really matters to you? And this question is so important, not just for ourselves, but also in engaging with service users and with our communities. What really matters to people. And during COVID, we've had a real opportunity, particularly to do that. And where we have been focused on common goals, that's always really much easier. But of course, we now have a much broader platform to explore. So let's just look then at the next slide and think about some of the aims of what we're trying to do here. So our quadruple aim, which many of you may have heard of or used before, enables us to think about how we improve the patient experience, the health of the population, reduce the cost of healthcare, and improve staff experience. So our whole aim of empowerment is to add value in that context, in that framework. And let's go to the next slide. If you look at this slide, you can see that the across our ICS, we've really embedded the opportunity to have great patient empowerment. And we've been working on this for many, many years. I'm sure many of you have too. And so our digital infrastructure in North East London really does focus on that level 3 patient access there, enabling people to review their own healthcare information, see their care plans and contribute to them, and be able to view and change upcoming appointments, often things that are really important for people in daily lives. And can I have the next slide, please? So I'm going to tell you a bit of a story now, which is how, from a nursing informatics perspective, we started to develop at Barts Health. And so it's a bit of a once upon a time in a land far away scenario, where we set out to implement electronic nursing records. And we'd already got a system in place, but we needed to really build on that and build a greater informatics strategy and vision. And I know that many of you on the call may be also midwives or AHPs, and we needed to really develop our NMAP strategy and vision and make a lasting difference for our patients, our communities and our teams. And so on the next slide, you can see that we really started by being clear on our purpose and intent, and wanting to champion the use of technology and informatics to improve practice, address unwarranted variation and enhance outcomes. And one of the really great things is being able to work with fabulous teams. And this quote on the top corner there, when you surround yourself with people who support your dreams, you will achieve success more quickly, came actually from one of the paediatric teams as we were going live, in their recognition of the fact that this was actually their dream and not just ours, which is a great reflection on how they felt much more empowered. So if we go to the next slide, please. One of the things that really inspired us was, as a collective, going to look at what was a possibility, a shared possibility, and develop a fabulous nursing informatics team, working with different people from our particular system partners. But the guy, Eric Vienmeyer, really inspired us in relation to his talk around overcoming barriers and doing the impossible. He used adversity as an advantage and was the first blind man to get to the top of Everest in 2001. And the challenge here was to think about who's on your rope team. So in empowering ourselves, who else is there to support you when things aren't quite going to plan, to keep you up, to keep you buoyant. And I have to say a great shout out for our nursing informatics team at Barts Health, who have been able to establish a wonderful connection across each of our hospitals and with our patients and communities to really empower people to participate. So if we go to the next slide, please. The other element that was important was that we formed a shared brand and a sense of real pride, and something that we developed was We Connect. And this enabled us, obviously, to have something that was recognisable. We had lots of green t-shirts, green cake, that's optional, that enabled us to really have something that was noticeable in the organisation. And this has really helped also future go lives and future developments. And people feel empowered as part of a team and very hashtag IT proud. So that's been a really great opportunity to put that in place and enable nursing teams to lead the way. And that really has been a brand that has started to be the indicator of how we do great nursing informatics. So if we go to the next slide, we can see that in order to develop our informatics structure and have what good looks like, we've really got to have people involvement and participation. This is just a real reflection of a small number of the team that were part of the electronic prescribing and meds admin go live. And in order to actually be able to do that, you've really got to focus on multiple moving parts, enable people really to participate and to be able to share their views and perspectives, to build the design, to co-design, to co-produce, and to include, particularly for specialist areas, the values and perspectives, not just of staff, but patients and communities too. So let's go to the next slide and think about inclusion for a moment. Something that's been important to us in this context is to widen it from just those people that are super passionate, but to people who are also super users. We developed from nothing 500 super users, a whole range of digital ambassadors. We've got a fabulous change team, and we were able to establish We Connect as part of a campaign and a series of pieces of communication, many of which are engaging and really fun things that really started to demystify for people some of the things that previously they were very nervous of in engaging in a full system and enterprise solution. And we enabled lots of community and patient involvement and participation, and we've got a particular group that also does that with us. And lots of education, learning and training. And our inclusion strategy is called We Belong. You will notice a theme here. So if we go to the next slide, please. We can see that what we tried to do is develop a social movement. So rather than focusing on old power, where the currency was there, where it was held by a few, it's about commands and leader driven. We moved to something that was much more around new power, where it was made up by the many. It was about uploading and sharing information, being peer driven and really open to suggestions, to change and to positive direction. It's important in this context, if we are empowering people as part of that social movement, to really know what and who you want to take action and how you want them to do that, but how you do that as a collective. Educate and think about what and really listen to what are people's concerns, make it popular, rally the troops. So it enabled us through all sorts of really fabulous competitions and a whole range of different things to enable people to be really part of something that was a social movement, in moving people from a real reluctance to engage in a digital solution to having it across all of our wards everywhere, and to be able to have planned that vision in 2018 to then implement it in 2019 as a refresh of everything, and to have it everywhere within that year was truly fantastic work, and took the work of many talented people in our organisation. So if we move to the next slide, please. You can see that involving our communities was important in that context. and really seeking first to understand and then be understood. So really listening to what people wanted. And we haven't necessarily been able to achieve everything yet. We've got a million things still to do. But important in this is how we empower our citizens and create digital inclusion. And one of the things we've found that's important is to ensure that we work with our community colleagues and Health Watch to enable that. So if we go to the next slide. We can see that we have generated a people in partnership framework that helps us to co-produce and co-design, which is really working well for us as part of our overarching strategy. And the next slide, please. And we can see just a few of the elements of difference that it's made. It's all about the impact and all about the change. Lots of information there that indicates that it's really making a difference for our patients. So that's the so what. Let's just go to the next slide and think about the fact that in and amongst all of this, it's important to make time to celebrate your accomplishments, no matter how big or small, and really think about the opportunities that that gives to empower a workforce. So that spreads like wildfire, enabling people to want to be engaged and part of this. And you can see the wonderful people here that are part of our core We Connect team from a nursing perspective. Great to see those people that are part of the Shuri Fellowship and those people that have been awarded a whole range of different things, which is really motivating and great to see. So if we go to the next slide, just to think about some reflections there. Really, that getting the perspectives during our programme has been really motivating and empowering for people, feeling that people were part of the decision making and that they were not in an us and them environment. Really important, not just for those people that are direct participants, but across an organisation. So if we go to the next slide and we start to summarise some of the elements, you can see here that there's a whole list of things that we're currently working on in relation to patient and resident empowerment that's really important. I'm sure many of you will recognise some of those, particularly if you think about some of the virtual wards and aspects there. And if we go to the next slide, we'll see that we can just summarise a few principles. So just keep it simple if we're trying to develop change and to put new things in place. Seek first to understand and then be understood. Involve and enhance participation. It's not just enough to engage. We really do need to create some energy and positivity there. So be proactive and inclusive. And don't be afraid if people are saying things that are contrary to your thoughts. Build them in, collaborate, facilitate, and build a shared solution and approach. Don't rush to be first past the post. It's not a competition often, and it's good to collaborate and learn from others, but most of all, enjoy. And so if we move to the next slide, please. A few thoughts to end on. Empower and influence. Think about the dynamics of change and improvement for you. What questions do you pose yourself? What actions? And are our energies actually targeted in the right direction? What's your intended purpose and way of working? Somebody described our team recently as nurses for whom no mission is impossible, which is a really great compliment. But the challenge I would say to us all is, whilst we as nurses, midwives, allied health professionals, often it isn't an impossibility, but sometimes we're given all of the things. And for us, it's important to decide what is the key thing we need to do in this situation to make it work. I just would like to focus on this quote. The Prince, many of you may have read that, was written for the haves. And a piece of work by a guy called Alinsky said that the principle here is to think about where we have the haves and who are the have-nots, and how do we move the power from the haves to the have-nots? And that's not just moving power from others to ourselves as practitioners. It's actually to enable us to be really clear on how we move that to our patients and the communities, who are often the people who don't have the power. So the last quote that I will reflect on is, "Never doubt that a small group of thoughtful citizens can change the world. Indeed, it is the only thing that ever has." So we started from a small group of people. We feel that we've changed part of our world. We've still got a lot to go, but the principle here is really about the next slide, which is where you start with just a small idea, a small acorn, and it definitely does grow. So wishing you success in all you do in empowering yourselves, your teams, your patients, and the community. So I think we're going to move to any questions now.
Hi, thanks. That was brilliant. You've got quite a few questions coming through. So if I start at the bottom, and for everybody watching, if you do want to ask any questions, there's the Q&A box at the top. Just post your question in there. And if you could like any questions that that are particularly poignant, it will help us to kind of focus on different themes. So the first question then is, how do you develop and empower those people that are advancing their skills and digital talents?
Yeah, really great question. So we're now so lucky that many of our practitioners and people in nursing or midwifery or AHP informatics posts are really advancing. And so never be afraid of that, and never be afraid that there are people that might be actually whisking past those people that are in leadership roles, because they are the future. So lots of opportunity to think about fellowships, master's degree programs, really support people, things like the Florence Nightingale programme, things like the Shuri fellowships, digital fellowships, and also opportunity to give them internships or shadowing opportunities to enhance not just the digital component, but their ability to lead and take things forward. So lots of opportunity to really do that and really build a great personal development programme with them. There's a whole range of mentorship and coaching opportunities too, and certainly through digital health. One of the things that we've been doing is providing a mentorship program across the CNIOs. That's so fabulous. You learn so much from each other actually, and it would be a great recommendation to do that collectively in all sorts of different ways across the country.
Perfect, thank you. So next question, great work. With the new power, including peer-driven, do you include collective leadership or shared decision-making as part of this?
Yes, really important. And as we talked about the, sorry, excuse me, the empowerment piece, really important to think about collective leadership, particularly also if you are in a multi-hospital organisation. And also across communities, making sure that people in the ICS all have an opportunity to contribute. And so a lot of that is about style, and actions speak louder than words as well. If I'm honest, in this context, really making it so that it can be open, collaborative and facilitative, so that everybody's views really sought and engaged, and that you can move forward with shared decision making. I think also the shared decision making councils and the opportunity for a whole range of people to be participants in that and feed in is just really fabulous, and we need to do more of that to engage and open that framework. Sometimes the golden thread and the amazing ideas and innovation come from areas or people that you never even thought of, and so important to include all.
Perfect, thank you. The next question's got quite a few likes then. So what were the types of concerns raised by people, and how did this impact on the changes?
I think actually right in the beginning, so that's a really good question. Right in the beginning, the main concerns were that people felt that they didn't have the digital capabilities. Other people felt that that there wasn't the hardware. They felt that the Wi-Fi wasn't robust enough. So all of those things that were really practical challenges were things that you've got to address in the beginning. You can't just brush them aside. So really important to assess what people's concerns, challenges, perspectives are. Have a sense of what the current state is, and don't delude yourself in that. Be really clear and really genuinely listen. And I think that many of the things that people were frightened of were also, you know, actually, I want to spend the time with my patient. Is this computer going to get in the way? Is all of this stuff going to just take hours of care? Is that going to add to the burden of care? So these are the things that we had to explore, and I think it's a constant listening exercise. We did a lot of work. Our IT colleagues did an amazing job of the hardware components and shoring up the Wi-Fi across all of our areas, and we constantly refresh that to make sure it's as fast and as reliable as we need. But unless you've got that confidence, it's very difficult to actually build on top of that. I think also that people felt that the focus would be so much on the wows, the computer screens, etc., and not on the patient interaction. And what was lovely recently, really phenomenal, and it was a bit of an unsolicited comment, was from somebody that was a patient, and this person was presenting to our board about something completely separate. And then they talked about how amazing that they felt. They felt secure and empowered because we'd got notes and things that were being written at the bedside, but she could see them. She could participate in that. The nurse was sitting with her and going through the screen with things in there. And she felt that that was such an amazing opportunity for her to feel safe and secure. And so some of the things that are actually the fears of the professionals, the patients and community teams feel slightly differently about it and are able to alleviate some of those fears. So really important to reflect on that. And the funny thing was with that often people talk about, oh, the elderly, you know, they don't use the technology. Well, they actually do. And the lady that I'm referring to came, she was 86 years old. She came with a laptop in case there was a bit of downtime, she could do something on her laptop. And she felt really digitally able herself. So a key here is to empower people, but also not make assumptions as to where we might need to provide support. But it certainly was empowering her and her perception of what we were able to do in terms of care and continuity, which was really important.
Thank you. Reminds me of my grandparents. They're always on their laptops and they're in their 80s as well.
Lovely, really nice.
So the next one we've got, okay, so this is around temporary workers. So how do you help those that are temporary workers or returning to practice that may feel disempowered or underconfident in their digital skills?
Yeah, really important. And I'm sure colleagues that are on this call will really sympathise with the fact that we may not always have all of our teams that are here as regular staff, and temporary staff are really a feature of our everyday, and it's really important for them to be included. And certainly bank and agency staff. And we've looked at different solutions, and in the beginning, actually, this was not a foolproof solution, I have to say. But over time, we've been able to enhance the education and learning component, make it more flexible for people. So don't assume that they can just drop into your sessions. Actually, how will you get the information to them? How will you make that easy? And there's no good coming up with a digital solution for that if the person is afraid of digital. So you've got to find a person-to-person solution that helps people feel confident. So we have spent quite a lot of time and energy on that. I don't think we've got it spot on yet. Certainly something we need to do more of. As we move through a digital expectation, and that being the way of working everywhere, it lessens as a problem. And of course, we've integrated this into a whole range of induction pieces, orientation, and lots of things that are flexible so that people can think about their skills. And also we provide drop-in sessions for when people are actually in the hospital, particularly during go live periods where they can access demos and a whole range of things. And the other thing that's important here is that not to assume that everybody learns in the same way. So build a learning framework, not a training framework, that helps people to think about how they would learn, whether that's at the elbow, whether it's clinical, whether it's simulation. Is it something that's very portable? Is it something that can be put through a CPD app and a whole range of things? So look at how the people learn, rather than, oh, here's a tick box exercise, put everybody on e-learning and that'll sort that out. So be practical but also personable in that, is what I would say.
Thank you. So I think we've got about another 5 to 10 minutes of questions, so there's quite a few still coming through. So how important do you think branding the digital team is? Is it best to stand out and be noticed, or do you get better engagement from being in the same uniform and blending in?
Oh, that's a good one. A bit of both, I think. Actually, that's a really good thought. I think we did some branding stuff, and actually the colour, I don't know whether any of my colleagues are on the call, but the colour was that sort of bright green, electric green. You'll see why we did that, and it did make us stand out. And actually, people do recognise that. However, not everybody particularly was in love with the colour of that, but it has been really helpful, because people do recognise, that's somebody that's really helpful. I can check in with them. But actually, to be quite honest, now they're so well known as the people themselves that and how useful they are. So the uniform or the contrast hasn't actually been a thing. One of the things that we have got, I'm sure some of you've got something similar, as people that are clinical educators that enable, we call them red shirts. They wear a red shirt, a polo shirt. That enables them to stand out purposely, so that people know, that person can help me in this moment, they're in the clinical area, and that's been great. And so I think there's a balance, isn't there? What we tend to do is, when we're going live with stuff, have lots of really visual things, and or if we're doing a campaign where we want to target things, we're really visual and we make sure that it stands out. And the rest of the time, I think we try and merge and blend and be part of the teams that really and that really builds a relationship, and it prevents you getting into silos. All of our people are integrated in practice, and that makes a big difference. So it's really real in terms of what's needed in the clinical areas. So a bit of both, I would say, if that's not sitting on the fence.
Not at all. I think we've got time for just one more question then. So the last question, and then we'll hand back over to Claire to introduce our next speaker. Lovely presentation. You mentioned about ensuring including all and not just those that shout the loudest. What do you do to ensure that you're including the vulnerable and underrepresented in your decision making?
Yeah, definitely. Really, really good perspective. We've got a raft of people across our organisation. One of the benefits from being part of the chief nurses team and the director of development is that not just the CNIO, is that part of my remit is also around engagement, participation with the community and patients. So that's been fantastic, because we've got a whole team there, and teams of people that work in each of our hospitals, and people that are responsible for community participation. So we've been able to explore that and build some of that thinking into the work we're doing, and making sure that we've looked at this also through an equity lens and an inclusion lens. So we have lots of things like world cafes and a whole range of activities that enable us to truly listen. We keep an eye, this is where data and information flows are really important, as well as the relational stuff. So that enables you to really check through, are you meeting with the right people, and are you enabling those people that are vulnerable in the equation to feed in? And some of the things we've been doing, for example, around sensory impairment being really important. And then how does that feed into the expertise within the system and the way in which we build that? So people requiring totally different solutions, obviously from a virtual perspective. So those people with hearing impairment, for example, or requiring BSL. So we have a tendency to have lots of development that targets purposely and proactively. How do we make sure this is an inclusive approach, and how does the digital piece fit into this whole framework rather than as being a silo? So using the power of the group, of the Barts Health group, has really helped us, but also using the power of North East London and enabling us to work with Health Watch and look at where we've got, where over time have we had issues, where are people saying, well, we've not been included. Well, let's go out and have conversation with them. Let's arrange proactively to talk that through. And that's enabling us to really not just impact our system and solutions here, but also some of the change and transformation in the organisation. So it's really fantastic. Thank you. I think I'm handing back now.
Thank you, Louise. That was fantastic presentation, and I'll be looking forward to seeing the slides myself and stealing your work, I think is what I would say. So as I mentioned earlier, any questions that have been answered, we will answer them offline and they'll be published then to the shared materials that we'll give you a link to at the end of this session today. So I'm going to hand over now to Kathy, who will speak to you. So I'll go off again now.
Hello everyone, good afternoon. So my name's Kathy Brewster and I am a service user representative or a public patient voice partner, and I have lived experience of maternity services. So before I had my children, I used to be a website developer, and so I'm really interested in how we can use technology to communicate and its potential to improve healthcare. So I'm going to talk a little bit about what it's like to be a service user in this digital space, and a bit about why and how we work with people to empower them, and how this works in maternity services across the country, and then a little bit about a national digital maternity project that I've been involved in called I Decide. So could I have the next slide, please? So this is a great illustration that explains why we need to involve people in our design process of our services. So I'll just let you take a moment to look at that. So next slide. Without involving the people that the service is for, we're not going to get the services right. So this is just some useful documents about how we work with people in NHS England. So there is the statutory guidance that applies to everybody about how we work with people in partnership. And that talks about different kind of ways of engaging with people. So there's things like inform, consult, engage, co-design and co-produce. And all these different kind of levels of engagement are useful for different things. And again, we have guidance and policy around how we actually work with people like me, patients, and involve them in NHS work. So next slide, please. So in maternity services, we're really lucky in that we have had a really sort of solid base around involving service users in co-design and review of services for a long time, and that started with what were called maternity service liaison committees a few decades ago, and this has kind of evolved and developed, and now we call them maternity voices partnerships, and we're starting now to include neonatal voice in that as well. But they started off as kind of multidisciplinary committees where service users would get together with clinicians and talk about services and how we could make them better. And now the way it's developed, we have sort of maternity voices partnerships leads or service user voice leads in maternity who are really getting embedded in those maternity services as, you know, the service user lead for the service. So whatever is happening in maternity, the clinical leads are involving service users at all levels in that work, and we're sitting at the board with people and we are making decisions and having influence. So we have Maternity Voices partnerships at local trust level. And then at ICB level or local maternity and neonatal system level, as it is for us, we also have boards where service users are represented. We have regional boards for maternity. Again, we have regional service user reps, and then national reps, which is my role. So not only am I a national rep, I also work in Greater Manchester with the local maternity and neonatal system as a service user voice rep there. So next slide, please. So just quickly, this is some of the different ways that Maternity Voices partnerships and service user reps engage community. So in maternity, it's so important that we talk to those that have the worst outcomes in maternity, and that is people from ethnic minorities or that live in areas of deprivation. So we go out into antenatal clinics, to children's centres, to community groups. We do online focus groups, we do surveys, and we really get out there into the community and gather feedback from people about what's important to them. And then we take that as service user leads into those strategic meetings with the service providers to help develop services. Yeah, linking with third sector organisations is really important, and also Health Watch are often involved as well. So next slide, please. Thank you. So in maternity, women are used to having paper records that they carry with them throughout their maternity journey. But in the long-term plan, there is a commitment to move towards digital maternity records for, handheld records for women. And these are some of the kind of apps that have been developed over the last few years around that ambition. One of the jobs of Maternity Voices partnerships is to get feedback from women about their experiences of using these apps, and then to feed that into the development of the app. So we often work with digital midwives, but the challenge is also working with system suppliers, and sometimes it can be quite difficult to influence at that level to shape apps and to work how we want them to, but that's an area where we've got a bit more development to do, but I will move on. So next slide, please. So this is a project that I've been involved in at national level in maternity, and it's all around informed decision making, which is what we call shared decision making in maternity, because it ultimately is the woman or birthing person's decision about what happens. This project's been running for quite a few years, and from the very beginning, the whole idea and concept was developed through a series of workshops with clinicians and service users, exploring what it was that we all needed to enable better conversations around different options during pregnancy and childbirth, understanding what those options really mean and the risks and benefits of them, and then how we document that and record consent. Next slide, please. So we started off developing some I statements for clinicians and for service users. So this is where the workshop came in, and we looked at what is it that service users really want from I Decide, what's going to help them for their informed decision making, and you can read it there. Next slide, please. So as we sort of developed the concepts around I Decide, it became clear that having evidence-based information for pregnant women and people to read and understand their options was super important. Clinicians also needed that, because in maternity there's a lot of uncertainty, and women want to understand what happens to people like me around their decisions. So if I choose to have an induction of labour, does that mean I'm more likely to have a caesarean birth or an instrument birth? And by providing really good data for clinicians, it helps them have those discussions with women. So we have information that women can read through the website and the app for I Decide, and then also is available to clinicians to help them have those conversations. So the digital tool is really about how clinicians record those conversations within our electronic patient records. So we worked with a system supplier around that to create the new fields and all the things that we needed and make it as easy as possible for clinicians to use. And so the result is that hopefully we have more informed conversations with clinicians and service users, and that we are having truly evidence-based informed decision making taking place. Next slide, please. So this is my last slide. So this is just gives you some idea of how the project actually developed. So on the left shows some of the imagery and things that we used around the project. And we, again, used a really diverse group of service users. We did focus groups to come up with the brand, help with the information, what information needed to be included. And that was really co-designed together with service users and with clinicians. And the screens on the right, they show a little bit about how the electronic patient record looked and how we developed that. And it's been a really interesting project to work on, and we've still got much more work to do. We've tried it out in 3 pilot trusts so far and had an evaluation, and we're looking to take forward the results of that and work on it some more. But I hope that gives you a little bit of a taster for how in maternity we involve people in digital work. So I think it's back to Nicole for some questions.
Hello, thanks for that. Yeah, so if anybody does have any questions, continue to put them in the Q&A and we will make sure we get to them. So let me have a quick look. For the first one then, has MNVP replaced MVP?
I believe that is the direction of travel. I know that there is a 3-year maternity plan that is due to be published imminently, and I believe that's the direction of travel, because we changed from being local maternity systems to local maternity and neonatal systems, and I think that will be reflected in the way that we listen to service users in maternity, and it will start to include neonatal as well.
Thank you. And then there's a question around barriers. So what are the barriers to putting citizens at the centre of service design?
Yeah, so I think there's lots of things, but what's things around going to people where they are. Don't ask people to come to you, because then you're only going to get, you know, a certain demographic of people that have got the time and the energy to do that. And the people that we really need to support with technology are those that are, you know, in areas of deprivation that don't have the time or you know, to come out to us, or might not have the means, you know, the bus fare to get to an event. So going to people in the community is a really important thing, and expecting them to come to you is a real barrier. And again, there's something around how we value people's time as well. So as service user voice reps, we are all remunerated in line with the NHS England policy around public patient voice partners. And we sometimes also offer incentives to people in the community to get involved and give their feedback and thoughts on pieces of work. We shouldn't be asking people to do stuff for free, because then we're not getting to hear from the people that we really need to. And then just thinking about people's sort of schedules and lives, and, you know, don't organise an event for mums when it's school pickup time, for example. You know, things like that really are a barrier to getting involved. Yeah.
Brilliant, thank you. I think we've got time on this one then, just for one more question. Kind of linking into the one you've just answered, what are the enablers then?
So I think finding some service users that can really kind of champion those voices. That's how we've done it in maternity. So you know, I was recruited to my role, but I had a lot of involvement at local level first. So it's finding people with the right kind of skill mix, and that they are people that you can have trusting relationships with as clinicians, because it can feel a little bit scary sometimes working with service users, and especially if you're really bringing them in properly into the decision making, you know, the strategic bits of your work. And there can, you know, I think there's sometimes a nervousness around that. So picking the right people to work with. And then the way we do it in maternity is then when we have those lay leads, they are the people that connect to the community and really bring in the voice. So I think getting that diverse voice is super important. So for example, in Manchester, we actually have quite a big Jewish community, and they have you know, quite different views about technology, and so it's really important that we think about them as well when we're developing digital tools.
Perfect, thank you. We can go back to Claire then.
Thank you very much, Kathy. And you know, I've done a lot of work with our local MVP and found them really, really helpful. In we've implemented an EPR here at Sherwood. So I'm going to introduce myself, and I could talk about myself for a long time, obviously. But for those of you who don't know, I am also the CNIO at Sherwood Forest Hospitals. I could change my background, but that would be a little bit ludicrous. So I'm coming to talk to you about digital volunteers. Next slide, please. So this clearly isn't me, but this I came into the role of the CNIO sort of mid-pandemic, I would say, and as I transitioned back into the office, I used to really enjoy sitting in our main entrance. So those of you that haven't been to Sherwood Forest Hospitals, our hospital's pretty spectacular. We have a PFI. So if you see on the next slide, this is our main entrance, and it's often likened to an airport lounge, but great place to sit and listen to users of our service, because it's quite echoey, quite loud. A lot of people stop and pause, and I used to sit and have my lunch in there. And what I was thinking, you know, about our service users and things like that. And on the next slide, you'll see me and my very best friend Sharon, who's also a nurse. We don't always wear matching stuff, but it's not unusual. So this is me and Sharon. We helped vaccinate the population of Nottinghamshire, and I still have the scars from that, I think. But what we learned from the vaccination centre is that we had a really captive audience. So when we're talking about patient-facing digital services, we almost had these citizens that we held to ransom, and that's quite a strong word, but we were able to help them to download the NHS app, and we did that with great success across Nottinghamshire and really got huge uptake of citizens taking the NHS app, mainly because they wanted to go on holiday. But you know, I was thinking about how can we help our patients at Sherwood? What can we do to help our patients at Sherwood? Because we're putting more and more things publicly facing, and we've heard from Kathy and Louise about empowering our citizens. And I thought, what can I do? I'm a CNIO at Sherwood. What can I do? And I thought, I've got a lot of people coming into my hospital every day, outpatients, visiting. So on the next slide, you'll see my new army. And it's a small army, but it's an army of digital volunteers. So what we have really a lot of at Sherwood, and it blew me away because it's not the first trust I've worked at. We have a lot of volunteers. We have a massive lot of volunteers, and I thought, what do these citizens, patients, whatever you want to call them, how do they identify with people? Do they want to be approached by what I call a two-thumb texter? So a two-thumb texter is a person that can text with their thumbs while walking and talking. Or I don't identify as one of those. I have to stop and text. Or do they want to see people like them, helping them to explain and use digital technology? And so I reached out to our volunteers coordinator and said, I'd quite like to have a little digital army of volunteers. And these were my first cohort. And and they are representative of our population in Mansfield and the local areas. So for those of you that don't know, we are a predominantly white British and Eastern European population. We have a high percentage of people with learning disability also in our community, and travellers. And I was really lucky that people started to listen to me. I think it's because I was new in post at the time and they were a little bit curious, but I managed to secure funding through what was then Connective Knots and is now Digital Knots, and we upskilled these volunteers with basic IT training. So how do you turn an iPhone on, how do you turn, you know, the difference between an iPhone and Android phone, where you'd find the NHS app, how they support people to download the NHS app, how to be able to navigate through the patient facing services that we put on. So we've got appointments, we've got letters, ordering a new prescription, things like that. And they work with so the idea is that they work with patients or people that are coming into the hospital, and people see you know, people like them that they're able to approach, normal non-authoritarian people. If we could just pop onto the next slide, please. So in January 23, we have this many. I can't. It's at 500,000. I'm not very good with numbers, even though I work in informatics. Of our patients in North Nottinghamshire have full NHS app registration. So that's just under half of our population, and I think that's pretty outstanding number, really. You'll notice throughout my reference, we're very proud at Sherwood of Robin Hood, obviously. And trees. So when Louise had her little acorn, we love an acorn. Next slide, please. So, and what we're saying is, so again, Nottingham Forest, we went to the Premiership for those of you that don't follow football. And what we said was what was possible when people share what they've learned. So what we're finding is that other people are then sharing that learning. So as you know, as we're teaching one member of the family, but they're sharing the learning throughout that family. We've seen a steady increase, and what we are seeing now is the digital volunteers are not being approached as much as they were at first. So, but we are about to bring some other stuff online, so I think there'll be some more interest there. So we're going to bring some results reporting to the NHS app very soon. Is that the end of my slides? Yeah. So yeah, thank you. So it's basically a simple idea. It's nice, and during Get Online Week, which was, I can't remember now, I've had a sleep, we had quite a lot of success. I think I've got some so during Get Online Week, we spoke to 251 people over the week and helped 75 patients download and use the functionality of NHS apps. So it's small numbers, we're a very small community. My next steps really are to reach out to my BAME colleagues and to help support those, and also to do some more with our learning disability population. So we have a huge training college near us called Portland College, and I'm hoping that they'll be able to support me with some videos in Makaton, particularly for our pregnant people that are accessing our service, because we are now all digital. And that's us, really. Small idea, works well, happy with it, and this has been replicated. So Connected Knots, Digital Knots now are using the same sort of idea to reach out to GP surgeries, and they do that service in GP surgeries, local libraries, places like that. Thank you. Oh, thank you for the love out.
Claire, we've got a couple of questions coming through. So first of all, gosh, my computer's frozen, that's not helpful. What prior skills and knowledge did the volunteers need?
So I went to our volunteer coordinator and just said, is anybody interested? Because I thought, you know, we don't want, I was keen that people, you know, like I talked about the two thumb texters, I was keen that people understood where our patient service users were coming from. So I wanted people to have maybe no knowledge or a little knowledge so that they could work through that same journey. And we did get a real mix. So we got some younger people, some older people. I think my oldest volunteer is about 82. But they came from very different backgrounds, and all they asked was, can you know, is it something you're interested in? Is it something you want to help somebody with? Because we have a lot of volunteers. So we have a shop they run, they do mealtime volunteers, we do library, a lot of things. So it's just an extra string to their bow. And this is generally what they do. The other offer, to make it a little bit more attractive, is that there's some back to work training that some of the volunteers have gone on to do. So they've done the digital basic training, and then as part of that, I've been able to offer them a back to work training skills to recognise what they've done. So that's been quite good for maybe people that have been out of work for a while. So I think we've had 2 go through to do that so far.
Brilliant, thank you. And there's one I'm just trying to publish now, so I'll read it out and then I'll publish it. Do you have a plan to review how long people volunteer for so they don't feel put on or run down?
Yeah, so our volunteer service is, I can't, when I first came, I was like, so I used to work at Nottingham University Hospitals, which is huge trust. And I came here and I thought, whoa, who are all these volunteers? So we've got another cohort of volunteers, and I'm going to do one more. And to be fair, the voluntary services run that, check in with them, make sure they're still happy. And I meet with them on a 3-monthly basis just to do a bit of catch up. And it gives them a bit of opportunity to give me some feedback as well. So I'm a big believer of, I think I don't know everything. Although my boyfriend would disagree with that, but you know, it's really good to hear their voices, to understand that direct feedback of, this isn't working for you citizens, you know, we need to change something. So that to me is a good conduit. But yeah, really, I'm very blessed to have a Tracy who looks after all the volunteers, feeds back to me, and I just meet with them once every 3 months and eat cake and biscuits. Really, it's fabulous.
It sounds lovely. We've probably got room for one quick question before we need to move on to the close. Matt touched upon it before, but how did you recruit your volunteers?
So literally it was just going and saying, does anybody fancy it? I know out in the community they've put stuff out on social media. I didn't really want to do that because I think that misses the point, because generally people that use social media are those that are already digitally confident, digitally active. So when the volunteers lady was able to recruit for me, so really blessed. I mean, I think it's going to be really hard to find somebody from our BAME community, because we just haven't got that out there. It's quite niche. But the LD community, I approached our local college and they've been fabulous. And also with we have Badgernet in our trust. It's very new, but we work with Maternity Voices Partnership as well to identify people that may be interested in doing that.
Perfect, thank you. I did say one more question, but I think this one's very important. Somebody's asked, what biscuits do they serve at the volunteer meeting?
So it's very good biscuits. So generally I go for a shortbread, but the other day they did make me carrot and walnut cake, so it's worth coming.
Perfect. Well, I will leave you to do the close now.
Thank you. So that's the end of today's session, and I think you'll all agree that we've had some fabulous speakers other than me. So just to let you know, if you could kindly complete the evaluation that we're going to share any minute now. And the next masterclass is on the 27th of April, and you'll be able to book your place with a link that should be shared as well. Now I'm worried because my screen's just got circles on, so I'm hoping that information's been shared with you.
Yeah, there's a slight delay on it, but both links will be put in the Q&A shortly.
Lovely, thank you, Nicole. So I'd like to close today's session. Thank you all for coming. Hope you found it really valuable. Please do give your feedback, and I will see you on the next session, which I think I'm chairing as well. I'm not sure. So sorry, you've got the short straw. Thank you very much.